Thank you, Dr. Gilligan. We appreciate that. Okay, let's see. I've got brief announcements. Here in this ballroom, we will have a lecture on advances in pharmacologic therapy for cardiovascular and kidney diseases. In ballroom 3C, there are lectures on medical malpractice and workplace violence. There's a 4:30 skill lab for teamwork communication. That's with Joshua Morris, who gave the lunchtime lecture on the cave rescue. That's in room 320. And also a skill lab for possible abortion care in room 312. Now, our next speaker is also sponsored by the Kidney Foundation of Utah and Idaho. Monique Cho is an associate professor in the Department of Medicine, Division of Nephrology and Hypertension at the University of Utah. Please welcome Dr. Cho. Here is a laser. That front button, if you want to use the laser pointer. And here are the slide advances
and
when backwards.
Got it.
Okay.
Thank you so much. Well, good afternoon, everybody. I'm very delighted to be here to talk about one of my favorite topics, SGLT2 inhibitors for kidney and heart protection. So I'm really honored to be here. I'm going to be giving you really a kidney-centric view of this since I am a nephrologist. And let me make sure I know how to use this. Here are my disclosures. All right, so what I like to do for the next 15 minutes or so is give you a quick review of the SGLT2 inhibitors, and I'm going to focus on the EMPA kidney trial that had not been resulted last time I was here a couple years ago, and I'm going to talk about one important sort of caveat in terms of SGLT2 inhibitors and CKD-use, and then I'll give you a very brief cursory review of the cardiovascular outcomes. And I'm also going to talk a little bit about the GLP-1 receptor agonists because this is a very exciting time with new trials coming out, a flow trial that is pending publication any moment now. And then there's not much new trial data to discuss with the MRAs, but I'm still going to talk to you about the non-steroidal mineralocortical receptor antagonists, which are actually becoming a mainstream part of the therapy for diabetic and non-diabetic kidney disease. All right, so we know that chronic kidney disease is one of the top 10 global risk factors for death. Here as it, I'm going to have to learn to use the, sorry. Oh. Let me see if, is it, okay, got it, sorry. All right, sorry about that. All right, so once you have chronic kidney disease, what's really important to remember is that the risk of dying from mostly cardiovascular cause is far greater than surviving long enough to reach end-stage kidney disease, and that's at every stage of kidney disease. So here, if you look at, does this actually transfer? No. So if you actually look at stage 4, the red bar here is looking at death, proportion of patients with death, versus the blue bar that's looking at renal replacement therapy like dialysis. And as you can see, even in advanced kidney disease stage at 4, the risk of dying far outweighs the risk of surviving long enough to reach dialysis. So this means that it's really important for us to identify any modifiable risk factors, treat and slow down the progression of kidney disease as much as possible. So in that sense, the Capital trial in 1993 was a watershed event for kidney world. This was the first study to show that ACE inhibitors can significantly reduce renal events, kidney events of doubling creatinine by 43%, 46% risk reduction for end-stage kidney disease event. So this was really quite remarkable at the time, made a lot of wave, and then it took 8 years to have the angiotensin receptor blockers to show similar results for type 2 diabetics. So this is now 2001, and since 2001, we really haven't had anything really to speak of until 2015, when the EMPA-REG trial, the first landmark trial involving SGLT2 inhibitor, came out. And it was quickly followed by multiple trials involving GLP-1 receptor agonists. And I will say that EMPA-REG trial tested the efficacy of empagliflozin as a cardiovascular outcome trial, and it was not anticipated that it would have such an enormous cardiovascular and kidney benefits. So really, I would say the SGLT2 inhibitors have given us unprecedented and unexpected benefit on the heart and the kidney, because it was supposed to be an anti-glycemic agent by blocking reabsorption of glucose. And we know that things have changed very rapidly. Soon after that publication of EMPA-REG, many other clinical trials of SGLT2 inhibitors followed, as shown in yellow here. Many of them are heart failure or cardiovascular outcomes trial, but there is DAPA-CKD, which was really the first designated CKD outcomes trial. And I will now also mention in green the Fidelio and Figaro, which are the first trials looking at non-steroidal mineralocorticoid receptor antagonists. And then we still have trials that have not yet resulted, which I'm going to get to in a little bit. SELECT trial is the first GLP-1 receptor agonist to be tried out for cardiovascular endpoints in non-diabetic patients with obesity and cardiovascular risk. So we'll be getting to these in a little bit more detail. Now, because these medications, which were meant to improve diabetic control, end up having such impactful benefit on the heart and the kidneys, there has been a significant paradigm shift to really emphasize the importance of interaction of metabolic risk factors in progressing the cardiovascular and kidney diseases. And so there has been a very recent presidential advisory from American Heart Association to coin a term, cardiovascular kidney metabolic syndrome. As a nephrologist, I like to say kidney cardiovascular metabolic syndrome, but this is a systemic disorder that is characterized by a close connection, interwoven connection between these factors. And it becomes really important to recognize every step of the disease process, whether it be from the risk factors all the way to clinical disease and organ failure. At every step, it is important to identify, modify risk factors, and try to slow down the progression. And in that sense, it is really important that we now have all these tools that we can use. Despite that, however, if you look at chronic kidney disease, this is looking at vast majority of the global patients, not just the United States. You have only about 20% of patients who are aware that they have chronic kidney disease. And among those 20% who actually know that they have chronic kidney disease, only about half of them are getting regular proteinuria screening or checkups, even though we know that reduction of proteinuria really significantly decreases progression risk of chronic kidney disease. But what's really important here is that almost after 10 years of EMPA-REG trial, the persistent prescription and use of SGLT2 inhibitors at 90 days is only at 5% globally. There may be many roadblocks for this. It may be partly expense, it may be some side effects, but I think as we become more familiar and comfortable with using this medication, hopefully we will have less discontinuing of the medication unnecessarily. All right, so let's actually talk about the kidney benefits of SGLT2 inhibitors and how do they work. Here's a picture of a nephron, and SGLT2, or sodium glucose cotransporter, is located in the proximal nephron that reabsorbs vast majority of the glucose that is filtered. And because it is so effective, typically when you have normal glycemia, you don't have any glucose in your urine, and that's because of SGLT2 in the proximal nephron. Only when your serum glucose levels go beyond 200 milligrams per deciliter, you start seeing glucose in your urine. Now, what happens with SGLT2 inhibition is that there may actually be hemodynamic effects because of this medication. So let's go over the normal physiology. If you look at the normal physiology here, It's the macula densa that regulates the afferent arterial tone to maintain GFR at normal level. What happens in early diabetes, or in cases where you have hyperfiltration, you have induction of SGLT2. Let's say you have hyperglycemia. You have increased SGLT2 that is reabsorbing sodium and glucose. That means there's a less delivery of sodium to the distal nephron, to macula densa. And that means macula densa thinks that it needs more flow. It's going to dilate the afferent arteriole to increase GFR. But that is the problem. When you have sustained GFR increase in hyperfiltration, that is exactly what predicts glomerular sclerosis and diabetic kidney disease. So if you have in your practice patients who are young or pre-diabetic or in early phase of diabetes and have very low creatinine, like 0.7 for a big guy, you should not be very happy. You should be worried about hyperfiltration, and you should be thinking about starting an ACE inhibitor, potentially whether you see that proteinuria or not. But a lot of those patients may have small degree of albuminuria that may be missed just looking at dipstick. So what happens when you actually use SGLT2 inhibitor is that you're blocking this SGLT2, you're blocking the reabsorption of sodium and glucose. That means you have a much greater degree of sodium delivery to the distal nephron. The macula densa thinks that you got plenty of flow. It's going to shut down or constrict the afferent arteriole, will reduce the GFR back to normal range. And that's how you can protect the kidney function all along, or at least one of the many mechanisms. And that means your creatinine may go up when you start this drug. And that definitely happens about 30% of the times. And it can go up as much as 30% or 30% reduction in GFR. It's not very different from starting an ACE inhibitor or ARB, where you may see a similar trend hemodynamically. It is not a cause for concern. In fact, it's supposed to do that. All right, so this is actually a very typical graph of GFR slope in all of the SGLT2 clinical trials, where you see an initial dip by about 4 to 6 millimeters per minute that you do not see in the placebo arm. All right. So what are some of the mechanisms that SGLT2 inhibitors may be able to give such profound protection for the kidney outcome? Well, we don't really know is the short answer, but there are many hypotheses, one of which is that there may be a direct cardiac benefit. And these data come from preclinical data where even though myocardium does not express SGLT2, it seems to have potential effect on reducing LVH, for example, and having antiarrhythmic effect. It may also increase ketone body, which we know it does, and that's a more efficient fuel type than free fatty acid. So that could be another source of improving energy metabolism. In terms of the kidney itself, by blocking this very energy expensive SGLT2 in the proximal nephron, you may actually conserve energy and better prepare for the kidney to deal with ischemic insult. And that's another theory, and that's been supported in some of the mathematical modeling and preclinical data as well. Now, because you're sort of offloading sodium delivery to the distal nephron in the medulla, which is relatively more hypoxic environment, there was initially concern that could we hurt the kidney by increasing workload for the medulla. Turns out we have not seen any evidence for harm, but it does seem to increase or induce hypoxia-inducible factor 1 alpha, which then increases erythropoietin production by the kidney. And we have seen uniformly in all clinical trials involving SGLT2 inhibitors an average mild increase in hemoglobin that may be due to because of induction of erythropoietin, and that may be one of the many pathways that may help and provide beneficial effects. And then, of course, there is significant vascular benefits. There may be direct and indirect benefit on the endothelium. So this is a very active area of research that is underway. I have a grant in actually trying to look at the vascular effects of SGLT2 inhibitors that I'm hoping for funding. Okay, so let's actually talk about the CKD clinical trials, and I want to sort of mention the differences in the patient population because I think that's going to set you up to understand EMPA kidney results a little better. So there are really largely 3 CKD trials. The first was Credence, but this was really a cardiovascular outcome. It's called CKD because they deliberately recruited patients with CKD. So everybody had to have albuminuria, 300 milligrams or greater, and their GFR was lower than the previous SGLT2 clinical trials. Now, DAPA-CKD, as I had mentioned earlier, was the very first truly dedicated CKD trial in the sense that it recruited down to GFR of 25, but it did require that you had to have at least 200 milligrams of albuminuria. Now, why is that important? When you have clinical trials, the way you sort of see whether it's a positive or negative study is by seeing the events. So the HERA events would be the kidney outcome, having of GFR or progression to end-stage kidney disease, what have you. So it's a dichotomous outcome whether you either have that event or you do not have an event. And in that setting, for analytic purposes, you need to have as many events as possible to have that be a positive study. And so in that setting, if you want to have a kidney disease progression as an endpoint, we know that people with proteinuria will have a much greater chance of actually progressing to end-stage kidney disease. And you don't want to be waiting for 10 years in a clinical trial setting. And that's why you're picking these high-risk patients, and that's why most CKD clinical trials will either have a GFR cutoff or they'll have a GFR cutoff with proteinuria, and most of them will require that you have proteinuria for that reason. Now, EMPA kidney was different. It is by far the largest, over 6,000 patients, but it had two different GFR categories. So if you had actually lower GFR category between 20 and 45, you didn't have to actually have any proteinuria. So there's about 20% of 6,000 patients or so in EMPA kidney who actually do not have any measurable albuminuria. And this is the first in CKD outcomes trial to actually recruit patients without any albuminuria, and we're gonna come back to this point. All right, so in DAPA-CKD, 40%, nearly 40% risk reduction in reaching the composite renal endpoint, as listed here in the green box. And the benefit was same whether you're diabetic or not. Now, the important thing, we talked about the acute dip in the GFR early on. And there was a concern that if you have very low GFR, like down to 25, are they going to actually have worsening GFR, and is that going to be a problem for these patients? So if you actually look at the change in the first 2 weeks when you first start and having this hemodynamic effect, as you can see in the patients with chronic kidney disease stage 2 and 3, so mild to moderate CKD, they had an acute dip that was less than 3 mLs per minute. If you look at patients who had GFR less than 30, they actually had a less dip in their GFR, almost half of it. So it seemed to be pretty safe from that perspective. And if you look at the chronic slope, meaning the GFR decline rate from 2 weeks to the end of the study, if you look at the more mild CKD patients, their reduction for the GFR slope was, their GFR rate was 1.73 mLs per minute reduction per year. And if you look at in the CKD4 patients, they actually had even better slope, more favorable slope. So they were reducing their GFR only by negative 1.33 mLs per minute per year. So in terms of safety profile, they also seem to be very comparable. So it seems to suggest that even if you have a lower GFR, the safety seems to remain pretty persistent. All right, and the benefit of SGLT2 inhibitors seems to be consistent regardless of whether you have heart failure at baseline or not. So this is a really great drug for both primary and secondary prevention of heart failure and for renal protection. So it's not just for people who have heart failure as well. And this is just to tell you that the kidney benefit is consistent regardless of whether you have atherosclerotic cardiovascular disease or not. So similar 30 to 40% risk reduction of reaching end-stage kidney disease or dialysis transplant, whether you have coronary disease or not. All right, so let's talk about EMPA kidney, which is really sort of the key point of the kidney aspect of this talk. So again, as I mentioned before, this was different from dapagliflozin in that it recruited patients down to GFR of 20, and it included patients without albuminuria. Up to 20% of the study cohort did not have albuminuria. Why is that important? Well, it's going to slow down the progression to chronic, to end-stage kidney disease, and there's a bigger concern that you're going to have a negative result when you do that. And so if you have a really powerful drug, despite this, you may see a positive result. Now, the important thing to remember with the EMPA kidney trial is that it was stopped early. After a median follow-up of only 2 years, the trial was stopped early because of overwhelming efficacy of benefit, and it wasn't felt to be deemed moral, ethical to continue the trial at that point. So while that is a great news, what it meant was that we started losing some power for some of the other secondary analyses. So what did we find in EMPA kidney trial? 28% risk reduction in the composite kidney endpoint of end-stage kidney disease, or sustained decline, GFR of up to 40%, or eGFR less than 10, kidney death, or cardiovascular death. So 28% risk reduction. You might say, hey, this is lower than dapagliflozin trial, which gave you 39% risk reduction. Remember, the study was stopped at 2 years. And so you missed out on some of the other events that you might have seen. So this was a by far shorter study by about 6 months compared to dapagliflozin. And that may be partly why you're seeing less of a risk reduction. And again, it involved 20% of the study cohort that did not have albuminuria. And it didn't matter the benefit whether you had diabetic kidney disease, hypertensive disease, or glomerular sclerosis, what have you. It really doesn't seem to matter. Remember that polycystic kidney disease is a very different disease. It's never included in any of the CKD trials, so it's not included here either. Now, as I told you before, there's that acute dip in the GFR in the first couple months, and then the slope improves. And if you look at the chronic slope, so that's the slope starting from the 2 months to the end of the study, this slope here. If you look at that in the empagliflozin versus placebo, there's a nearly 50% reduction in the decline rate. And I don't know of any other drug out there that can match that. So what this means, if you look at the absolute term, we're talking about a difference of 0.75 in the total slope that's from the beginning to the end. And then in the long term, the chronic from 2 months to the end of study, 1.37 mLs per minute per year decline rate. Now, you might not say that doesn't seem like a lot, but if you multiply it by 10 years, we're talking 14 mLs per minute. And that's a big difference between whether you need dialysis or not. And in fact, there are studies sort of looking at calculated risk of starting dialysis, and based on some of the data, you may be able to postpone dialysis by 10, 15 years, and that's a huge win, no matter how you put it. So these little numbers, that may not seem significant, but it is very significant over time. Okay, so in the expense of time, I'm gonna skip this slide. One of the key controversy or question in the nephrology world was, will SGLT2 inhibitors be helpful and effective in non-proteinuric CKD? Because if you think about it, the RAS inhibitors, the ACE inhibitors, and ARBs, they're not very effective when you don't have proteinuria. They may be effective for other reasons, but they're not as effective in slowing down the CKD progression. So this was always a big concern. What do you do with patients who don't have proteinuria? And EMPA kidney is uniquely designed to try to answer that question. Now, this is from the article that was online, published in November last year, 2022, and then on paper form in January 2023. And if you're looking at the primary endpoint of the renal composite and outcome, and if we're looking at whether you have diabetes or not, again, there's a benefit. So this is a forest plot. So if you're on the left of this one, empagliflozin is going to give you more benefit versus placebo on the right of this line over the one, because this is the hazard ratio that we're looking at. So whether you're diabetic or not, yeah, there may be more benefit if you're diabetic, but still, this is equally effective. If you have a GFR at different categories, it also doesn't seem to matter. You're still going to benefit whether you're less than 30 or above 45. Now, the big caveat was the albumin to creatinine ratio. If you have normal albuminuria, less than 30 milligrams per gram, is there a benefit here? What about if you're up to 299 milligrams per gram? Is there a benefit here? Well, it looked like from this that the benefit is limited to those people who have albuminuria at least at 300 milligrams per gram. And this was a big question that got raised, and there was a lot of caution that was thrown at the readers that this study wasn't designed specifically to ask this question, so you have to be very careful. Now, what they did in the most recent publication, they actually, so remember I talked about the dichotomous variable as an outcome, and you either have to have it or don't have it. When you look at slope, that's a continuous variable, and it actually gives you more power to look at the effect of an intervention. So the EMPA-Kidney Collaborative Group actually did a very smart analysis looking at not the endpoint of kidney events, but at GFR slope, and see what happens when you have no albuminuria or moderate or severe amount of albuminuria. And again, this is looking at the forest plot. So here is the 0 line for hazard ratio. Below this, placebo would be better. This is, again, talking about GFR decline here. On the right of this is where empagliflozin actually helps you reduce the decline rate of GFR. Now, again, as expected, yeah, maybe if you're diabetic, the benefit is greater, but you're going to benefit whether you're diabetic or not. Same thing with GFR categories. Now, if you look at those patients with no more albuminuria, less than 30, look at this. The benefit, the absolute difference in the slope was 0.78 mLs per minute per year. That's how much you slow down compared to placebo, even when you don't have albuminuria. So again, doesn't seem like a lot, but you add 10 years to that, we're talking about 8 mLs per minute. That's a difference between dialysis or no dialysis. It's a big deal for our patients. So I think that the data are pretty consistent that even if you don't have any albuminuria, SGLT2 inhibitors may slow down the progression of chronic kidney disease, and lack of proteinuria should not be a reason not to start SGLT2 inhibitor. So I want to make that really clear, because even among us nephrologists, we're still arguing about this. If you're not convinced, remember that EMPA-REG, CANVAS, CREDENCE, or EMPA-REG and CANVAS trial in particular, these patients did not have chronic kidney disease, did not have albuminuria, and there was a 40 to 50% reduction in renal events in those trials. And if you look at cardiovascular death, whether you have CKD or not, the benefit is still the same. So if you can't do it for the kidney benefit, do it for the heart. All right, so no difference in the adverse events whether you have lower GFR or more preserved kidney function. So let's go on to the heart trials. Here we're really talking about, there are many more trials that will not fit on this table, but what I want you to really focus on here is if you look at the heart failure hospitalization, because that's really where the power is for this drug, 30% risk reduction across all trials. There was a slightly less for the HAP patient clinical trial where for the heart failure was preserved ejection fraction, but remember that SGLT2 inhibitors are the only class of medication proven to reduce heart failure with preserved ejection fraction hospitalization. The other trial, TOPCAT, using spironolactone, was actually a negative trial. All right, so again, with the chronic cardiovascular outcomes, it doesn't matter where your GFR is. It seems to be equally beneficial, and whether you have ischemic or non-ischemic cardiomyopathy, it doesn't seem to matter either. And I want you to this is sort of the grand summary of the cardiovascular trials, and I want you to focus on the fact that, of course, the heart failure hospitalization reduction is the main efficacy of this class of medication, about 30% risk reduction across all clinical trials. But remember that this also has a benefit on atherosclerotic cardiovascular disease. So 12% reduction in MACE, major adverse cardiovascular events, and MI. And it also leads to cardiovascular death and all-cause mortality reduction by 15%. Now, it has been noted that in many of these heart failure clinical trials that sudden death risk was significantly ameliorated in patients who were receiving SGLT2 inhibitor by 33%. And even when you look at AFib, atrial arrhythmia, there's consistent finding that it seems to reduce the AFib by 14%. So this led to a whole bunch of other clinical trials that actually are now looking at the primary endpoint of arrhythmia, ventricular arrhythmia. So some of those actually include the EMPA-ICD, looking at patients with empagliflozin on ICD, whether they have better outcome. Same thing with ERASE is another trial that's ongoing that's looking at severe HFrEF patients with ICD placement. So I think we're going to learn a lot more. The cardiologists have been quite active. They have tried out SGLT2 inhibitor not only in heart failure, but also in acute MI, acute heart failure, and in acute heart failure patients, when you start this class of medication as a new drug, it seems to actually improve the outcome as well. So cardiologists are ever expanding the indication for SGLT2 inhibitor, and we may be probably hearing about the effect of this class of medication on ventricular arrhythmia in the near future. All right, so in summary, there's consistent kidney and heart failure benefits across all randomized clinical trials. Now, I didn't focus on this as much, but the kidney benefit, when you look at the Kaplan-Meier curve, starts becoming evident at about 12 months. Whereas with the heart failure, the Kaplan-Meier curve starts splitting almost immediately. And so the benefit actually is seen almost within 3 months. Now, the kidney composite endpoint is reduced by almost by 40 to 50% in some studies, 29% in EMPA-REG. And remember, lack of proteinuria should not preclude you from prescribing this class of medication. But there may be greater benefit in those patients who have greater amount of proteinuria at baseline. And remember that SGLT2 inhibitors also reduce atherosclerotic events by about 12%. So it's not just a heart failure drug. And it may potentially give us a ventricular arrhythmia benefit as well. So we'll have to see how the story ends with that. So the main adverse effects that you worry about really are euglycemic diabetic ketoacidosis. That's really by design because this class of medication does increase production of ketone bodies. So that happens regardless, but because of that, in some cases, if you have patients who are going to be undergoing more stress or fasting, there may be an increased risk for ketoacidosis, particularly in diabetics. There are no reports of DKA in non-diabetic patients that I'm aware of. Myocardic general infection, really far more than UTIs. These are usually pretty treatable with 1 dose of fluconazole. So this is no reason to stop the drug. I repeat, there's no reason to stop the drug for UTI or myocardic general infection. And if you do end up doing that, it can just be a brief break, but you should be able to restart pretty quickly. You need to avoid volume depletion because obviously this has a natriuretic effect. All right, the fracture was only seen in Canvas trial and it has never been seen in other trials, so we're not sure what to make of that. So general strategy that I like to discuss is that you want to consider SGLT2 inhibitor for anyone who's got chronic kidney disease, particularly if they have proteinuria, or even if they don't have proteinuria or chronic kidney disease, if they have heart failure risk. Clearly, all diabetics should be, type 2 diabetic that is, should be strongly considered to start this medication, or anyone with proteinuria, I would say, regardless of their GFR or cardiovascular status, if the maximization on RAS inhibitors still leave you with residual proteinuria. Now, it's important that this medication does have natriuretic and diuretic effects, so you don't want to be starting this medication along with other agents that can cause volume depletion. And again, if the creatinine bumps, and it can bump up to 30%, usually it will happen within a month. Within 2 to 4 weeks is when you start seeing that. Don't worry, you don't need to hold the medicine. You just need to repeat the creatinine within a couple weeks or so. It should be stable. And so it's just like ACE inhibitors where you do not need to stop for that acute rise. Again, it's that hemodynamic effect, and that's what's actually going to protect the kidney over the long haul for those people who are hyperfiltrating. All right. So who do I not start SGLT2 inhibitors? People who have history of DKA, particularly if they have it more than once, or in recent past, these patients are prone to more DKAs. So I'm going to be very, very careful with those patients. DKA can be the actual reason to never re-challenge because it can be potentially fatal. So that's a big one. The frequent general infection, that's really going to be case by case, depending on the reason, underlying cause for that. If patients have obstructive physiology and you're concerned that they're going to have increased risk for bladder or general infection, that may be another consideration. Polycystic kidney disease, there are absolutely no data of efficacy. In fact, there are some preclinical data to suggest that it may enlarge the cyst size. So I do not use SGLT2 inhibitors in patients who have polycystic kidney disease. Type 1 diabetics, we think probably will have same benefit. We just don't know the safety because there's an increased risk for ketoacidosis. So there are ongoing clinical trials in Europe using SGLT2 inhibitors in type 1 diabetics, but it's not a routine standard practice right now. All right, so let's talk about the GLP-1 receptor agonist. I'm gonna have to speed up a little bit. So GLP-1 or glucagon-like peptides are naturally occurring peptide made in the intestine. They reduce insulin and increase glucagon. They have a whole host of metabolic effects that we don't fully understand. It's important to note that the receptor for GLP-1 are present in a variety of tissues, including the brain, heart, vasculature, kidneys. And in fact, it's the activation of the hypothalamic GLP-1 receptor that affects the satiety, and that's one of the reasons why you lose weight on this class of medication. Now, what's really important, unlike all the other anti-diabetic drugs, GLP-1 receptor agonists are very heterogeneous. So one agent in the same class is not equal to another agent in this class, and you have to be quite aware because they're going to give you different pharmacokinetic properties, different efficacy, and different safety profile. So this has mostly to do with the peptide base, the backbone of the amino acid structure of these pharmacologic agents. So we have the shorter acting ones, which are mostly driven from the non-mammalian exendin 4, as opposed to the human analog of GLP-1. So the drugs that have the human GLP-1 analog tend to have the longer acting properties. They tend to have higher efficacy. They also tend to have lower GI side effects. So I think since the earlier days, we're no longer using short-acting drugs for any of the clinical trials. All the recent data are really using the long-acting ones exclusively. So we know that the GLP-1 receptor agonists have shown moderate efficacy to reduce MACE by 14%. That's major adverse cardiovascular events like MI, and all-cause mortality reduction by about 13%. And as you can see, cardiovascular death, stroke, and MI. And so with this, but this is all in type 2 diabetics. So there was a question, will GLP-1 receptor agonists also work in non-diabetic patients? Remember, this, like SGLT2 inhibitor, was developed to be a diabetic drug initially. And of course, now we use this for obesity as much as we do for diabetics. So that question, can this be protective, particularly for cardiovascular events in non-diabetic patients? That's the SELECT trial that was just published not too long ago, and this was 17,000 patients, over 17,000, a huge trial, who do not have type 2 diabetes, but have pre-existing cardiovascular disease or risk for it. And so these were patients who were randomized to placebo or semaglutide, and what you can see on the top panel there, 20% risk reduction in the primary cardiovascular composite endpoint, which was composite of CV death, non-fatal MI, or non-fatal stroke. So this was created a huge buzz at HAA meeting in Philadelphia last November, because this is the first trial of its kind in non-diabetic patients using GLP-1 receptor agonist. Now, if you look at their sort of metabolic profiling, the very first bar graph here is at baseline, and this is at 2 years or week 1 of 4. And as you can see, in the semaglutide arm, by the end of 104 weeks, you have 12% of participants who actually went from being overweight to non-overweight. So BMI below 25. When you look at the placebo arm, really not much change there. And this was also associated with significant change in the waist circumference, and the mean body weight change was about 9%, but there were about 5% of the participants lost more than 25% of their body weight, pretty significant. All right, what about the kidney endpoints with GLP-1 receptor agonists? Well, the story here is not as consistent. Initially, this was touted as kidney protective drug, but all of that was because of its ability to reduce albuminuria. So if you look at this forest plot again, this is looking at a composite endpoint, but it was all driven by reduction of albuminuria. If you look at the worsening GFR, renal replacement therapy, none of these were actually significant. So in the earlier landmark trials, it was felt that, well, it seems to lower albuminuria, but that's about it. But remember, all of these were diabetic patients with cardiovascular outcomes. They were not selected for kidney disease outcomes. So the question remained, and that's why the FLOW trial was designed. Now, FLOW trial was resulted, and it's actually completed, and the preliminary results were presented at ASN and AHA meetings last year, but I still have yet to see the article, but I think it's going to come out in publication, probably in New England Journal of Medicine any moment now. The study included patients with, this is diabetic patients now, type 2 diabetic patients from 28 different countries. Again, everybody had to have some degree of albuminuria. The limit for albuminuria was dependent on your GFR range, kind of like EMPA kidney, but nobody was allowed in unless you had some degree of albuminuria, at least at 100 milligrams per gram. The short answer to this is that there was an overwhelming 24 risk reduction of the primary kidney composite endpoint with semaglutide versus placebo. So this is the first ever clinical trial of GLP-1 receptor agonist as a truly dedicated chronic kidney disease outcome trial. And so it made a huge buzz at American Society of Nephrology last year, because up to this point, GLP-1 receptor agonists were really considered to be metabolic drug, weight loss drug, diabetic drug, with some benefit on cardiovascular endpoints, but not so much on the kidney part. But this may change how we think about GLP-1 receptor agonists and may actually become an important arsenal in our toolkit. All right, so just a couple words about using GLP-1 receptor agonists in CKD. Remember, with SGLT2 inhibitor, we only know safety data down to GFR of 20, because no one was recruited below that. But with GLP-1 receptor agonists, particularly the long-acting ones, in particular liraglutide, dulaglutide, and semaglutide, seem to be quite safe in CKD4 and even in dialysis patients. There are clinical trials in dialysis patients using these medications seem to suggest safety, although you may need to monitor them more frequently. So this is definitely a big plus that you can use them in end-stage kidney disease. I would definitely avoid the short-acting ones altogether. And they are also more likely to be excreted by the kidneys, whereas the long-acting ones are not. All right, so in brief, a few minutes, I'm gonna talk about the MRAs. Why MRA? Why is mineralocorticoid receptor agonist important? Well, because we know that aldosterone is a huge bad player when it comes to fibrosis, hypertension, and inflammation. It has a variety of really adverse effects on the kidney and the heart, and certainly on the blood vessels as well. So we, for decades, have tried to block this mineralocorticoid receptor in hopes of lowering blood pressure, preserving kidney and heart function. The problem has been, of course, the side effects, gynecomastia, hyperkalemia. So because of that, it took a long time. The spironolactone was available in the 1960s. It wasn't until in the early 2000s that the second generation of MRA, Plerone, was developed. And I'm going to go over the difference in the next slide. And then, of course, very recently, we now have the third generation, the non-steroidal mineralocorticoid receptor blocker. So before I get to that, I'm going to actually tell you the importance of adding mineralocorticoid receptor blocker with an ACE inhibitor or angiotensin receptor blocker when it comes to reduction of proteinuria. So this is 41 participants with some degree of CKD and pretty significant amount of proteinuria at 2.5 grams per day. And this was a small study, but it was a very meaningful study. It has a reverberance to this day because this is how a lot of nephrologists will practice. They will add an MRA like a spironolactone on top of ACE or ARB rather than adding ACE inhibitor with an ARB if you want to reduce proteinuria. So what you're looking at here is that on the baseline of ramipril study alone, if you add irbesartan and ARB, you get only a very modest reduction. Not significant, as you can see the confidence interval there. But if you add spironolactone to ramipril, there's a 42% reduction in proteinuria on top of probably 30% that you were getting with ramipril alone. Now, if you add ramipril, irbesartan, and spironolactone, just do all three, you don't get much bang for that buck. In fact, you just get more hyperkalemia. So we don't recommend that. But it's because of these data that I have a preference to use spironolactone with an ACE or ARB when it comes to reducing proteinuria. And it tends to give you typically about average of 30% reduction, additional 30% reduction in proteinuria, which translates to preservation of kidney function. So if you look at the cardiovascular outcomes using MRAs, the RAILS trial in 1999 was the very first one and made a huge splash. This was the first study to show that there was a 30 to 35% risk reduction in heart failure. Was a big deal. The second generation of Plerone followed suit, but it was actually then applied to the heart failure with preserved ejection fraction. That's the TOPGET trial. And unfortunately, that ended up being a very close call, but was insignificant. And that probably has a lot of different reasons for that, because HFpEF is such a heterogeneous disease, much more than HFrEF. So that's not all that surprise. But what happened after RAILS trial was that there was such a rush to use spironolactone in heart failure patients that there was an increased risk of hospitalization due to hyperkalemia. And then that ended up dampening the interest in using spironolactone or MRA in general for heart failure. It just became very difficult after the RAS inhibitor to add spironolactone on top of that, ended up being very challenging. So why do we need yet another MRA, the non-steroidal mineralocorticoid receptor blocker, finerenone, which is the newest kid on the block? Why? Well, there are significant differences, and there may be different indications of where you might prefer finerenone over spironolactone. So let's go over that. So if you look at spironolactone, the first generation, it has a very poor selectivity for mineralocorticoid receptors, so it's going to activate your other steroid receptors. That's how you get the gynecomastia, the sexual side effects. But it's very potent, and it has a huge antihypertensive efficacy. That's the benefit of spironolactone. If you need to reduce someone's blood pressure, this is the drug to use among the MRAs, not a Plerone. Now, Plerone is the second generation. It is much more selective, but it has lost out on potency, unfortunately. So it has a much less antihypertensive efficacy. So if your goal is to reduce blood pressure, and blood pressure for most, spironolactone is still the way to go. In terms of hyperkalemia, there's no difference. It's just less of gynecomastia, these other side effects. But hyperkalemia still is similarly problematic for a Plerone and spironolactone. So what is the difference with the newest kid on the block, finerenone? Well, it's non-steroidal. It's very, very selective. over 500 times fold more selective. You will not get gynecomastia, you will not get these other side effects, and it has not lost out on any of the potency in terms of blocking the MR. Now, the other really important difference here is the tissue distribution. When it comes to spironolactone, it's mostly in the kidney. So eplerenone is more in the kidney, not as much. When it comes to finerenone, the distribution is equal between heart and the kidney. So this might potentially maybe give you more heart benefit. We don't know. We don't have a head-to-head comparison, but that is something to note. All right, so another huge difference is that it's not much of a blood pressure reducing agent. On average, it reduces systolic blood pressure by about 3 millimeters mercury. So it's kind of like a SGLT2 inhibitor. If you need to lower someone's blood pressure, finerenone is not the drug to use for that. Spironolactone is. But if you need someone who's got soft blood pressure because they're maxed out on standard therapy, but you need that yet another drug to help with heart failure risk, that's your guy. All right. So this is the Fidelio, the very first trial using MRA ever for kidney CKD endpoint. So this is in type 2 diabetic patients. Again, the reduction in the composite kidney endpoint was about 18% there. So it's comparable to Renal or IDNT trial with ARB in type 2 diabetics. This is on top of the standard therapy, obviously, and many of these patients, or some of them actually, this is earlier on, were on SGLT2 inhibitor as well. So when it actually comes to proteinuria reduction, it's quite similar to adding spironolactone, additional 30 to 40% reduction in proteinuria on top of your standard RAS inhibitor therapy, or SGLT2 inhibitor for that matter. Now, what about hyperkalemia? Is it any better with hyperkalemia? Well, initially in this trial, they sort of discussed that the discontinuation rate of the drug because of hyperkalemia was 2.3% as opposed to 8% in the RAIL study with spironolactone. But I think in reality, the hyperkalemia concern remains. It's still a concern. The difference now is that we have potassium binders that are very effective. So rather than avoiding these very beneficial drugs, what I do is just start them on Lokelma or Patermer to bind the potassium so that it allows me to continue with the renal protective therapies. All right, so Figaro is the other twin trial that sort of used a similar patient population as the Fidelio, but the endpoint here was incident heart failure hospitalization. So this is type 2 diabetics, and again, only 8% of the study cohort actually had heart failure history. So predominantly, this is a primary prevention trial. And again, similar to SGLT2 inhibitors, 32% reduction in heart failure hospitalization in these type 2 diabetics who mostly did not have heart failure history. So this is the first trial, landmark trial, to show specifically that selective non-steroidal MRA, finerenone, may prevent development of heart failure in type 2 diabetic patients who do not yet have it. So there you have it. So the summary here, again, as I said, the non-steroidal MRAs are different from the previous iterations of these in the sense that it doesn't have as much lowering effect on the blood pressure, but it's highly, highly specific for the mineralocortical receptor, and it seems to have truly significant efficacy in preventing heart failure in diabetic patients. We do not yet have data in non-diabetics, but those are in the works right now. So overall, I would say that SGLT2 inhibitors really give you the most potent overall protection for the chronic kidney disease and heart failure, whether you're diabetic or not. This is the only class of medication that we have equal amount of data in non-diabetics as well as diabetics. And remember that SGLT2 inhibitors also give you a 12% reduction in atherosclerotic events as well. And importantly, from the AMPA kidney trial review that I just did, lack of proteinuria does not mean that SGLT2 inhibitors are not going to be effective. It may take longer for you to see the benefit, but it is no reason not to prescribe this medication. So I really want to make that clear. Now, GLP-1 receptor agonists, remember, there's a lot of heterogeneity. I would only stick with the long-acting versions, not the short-acting individual drugs that came out earlier. There's a significant weight reduction. It's really the king of the metabolic drugs. It does have a moderate efficacy to lower MACE, very comparable to SGLT2 inhibitors. It doesn't seem to have as much effect on heart failure. So if you have somebody with heart failure, you want to go with SGLT2 inhibitors and not GLP-1 receptor agonist. With finerenone, again, this is the drug to use to prevent heart failure or chronic kidney disease progression in diabetics right now. This is yet another tool to use. We don't have the data in non-diabetics yet, but I think the result probably will be very similar. And again, important to remember, this does not lower the blood pressure so much. So if you need to lower the blood pressure, spironolactone is a better way to go. All right, so how do I put all this together? There's so many drugs all out there. How do I choose which one to use? A lot of times it's a moot point because you're going to be using all of them. But if you had to pick and choose, let's say you have patients with, this is actually everybody in my clinic, almost everybody, kidney disease or cardiovascular risk profile or obesity or diabetes. Now, if you have GFR that is very low, less than 20, remember, SGLT2 inhibitors are not approved for initiating in patients who have this low GFR. Now, patients who were in the clinical trial, when they fell below 20, started dialysis, they actually continued on the drug. So once you start the drug, you don't have to stop because the GFR drops below 20. You don't want to stop. In fact, you only stop when they start dialysis. I actually have an ongoing trial right now that's NIH funded that is looking at safety and tolerability in hemodialysis patients. There is an ongoing similar study in Europe. So we're going to start to gain data about using SGLT2 inhibitors in dialysis patients in the near future. But for now, you're kind of stuck with patients who are GFR 20 or above. So in those patients, remember, if they have obese or other metabolic risk factors or atherosclerotic disease, GLP-1 receptor agonist will be your first-line therapy. And depending on the hyperkalemia issue, you may also be able to use MRA, finerenone. Now, if you have a GFR that's somewhere in the mid-range from between 20 and 60, this is a range whether, particularly if you have albuminuria, and you may have a risk for heart failure or a history of heart failure, this is definitely an indication for SGLT2 inhibitor as a first-line therapy, in my opinion. And even if you didn't have proteinuria, if you have CKD or have heart failure, SGLT2 inhibitor still would be my first-line therapy in that case. Because GLP-1 receptor agonists can also lower proteinuria, and it may actually improve or slow down the CKD progression, GLP-1 receptor agonists may also be useful in that setting as well. If you have preserved kidney disease or GFR above 60, but your heart failure risk outweighs the risk of atherosclerotic disease, again, SGLT2 inhibitor would be the way to go. And I would actually have a very close second as a non-steroidal MRA. If you have a greater risk of atherosclerotic disease than heart failure, by all means, GLP-1 receptor agonist would be your first choice to go. So this sort of breaks down how I think about SGLT2 inhibitor, GLP-1 receptor agonist, and MRAs. So I'll end here and leave about 90 seconds for questions. Thank you very much. Sorry. Yeah, any questions, please? Preference among the different choices of SGLT2 inhibitors? No, not based on the data we have available. They all seem to be pretty similarly effective. There may be a difference between canagliflozin and AMPA or DAPA because cana is not as a selective SGLT2. It does have some SGLT1 blocking efficacy, but clinically so far we're not seeing much of a difference. So I think really any of the agents. Yes. Any other questions? Okay. Thank you so much for sticking with me to this late hour.
Thank you. Thank you. Thank you, Dr. Cho. Okay, let's see. Brief announcements. Tonight is the Ogden Regional Medical Center dinner, honoring Dr. Kirsten Baca, who's the president of the Ogden Surgical Medical Society this year. There will be dinner and entertainment with the Scott Andrews stage show of mystery, mind reading, and metaphor. So that sounds kind of exciting. That starts at 6:30. I hope that if you're coming, you have registered in for that. If you have not registered in and are planning to come, rush right out and hope that there is a ticket available for you. Okay, tomorrow night is the Holy Cross Hospital, Davis and the Tanner Clinic family night at the Sequest at the Layton Mall from 6:30 until 9. Some of you may have been that before. That's a good place to take any children or grandchildren also. Thank you for attending today. These days get kind of long. We start early and we go for a long time. Thank you for coming. We'll see you tonight or tomorrow.